Hi, this is Dr. Nithila doing my MD Anatomy at ESIC Medical College and Hospital KK Nagar. இன்றைக்கி நம்ம வந்து ப்ரீவியஸ் இயர் அனாட்டமி கொஷின்ஸ் எம்ஆர்பி கொஷின்ஸ் பார்க்க போகிறோம். எம்ஆர்பியில் வந்து அனாட்டமிலேருந்து ஆவரேஜாக ஒரு 2 to 3 கொஷின்ஸ் per year கேட்குறாங்க. அதுவும் வந்து மோஸ்ட்டாக கிளினிக்கல் அனாட்டமி அண்ட் எம்ப்ரியாலஜி கொஷின்ஸ் தான் கேட்குறாங்க. ஸோ அதை தான் இப்போ டிஸ்கஸ் பண்ண போகிறோம். நீங்கள் வந்து இதுக்கு அவ்வளோ டைம் ஸ்பெண்ட் பண்ண தேவையில்லை. ஜஸ்ட் see the previous year questions and also the clinical anatomy of each topic. All of the following are commonly seen in a dichorionic twin pregnancy except a lambda sign in USG, twin-to-twin transfusion syndrome, intertwin membrane thickness of more than 2 centimeters, babies of different sexes. So the answer is twin-to-twin transfusion syndrome. So we'll see about dichorionic twin pregnancy. Dichorionic twin pregnancy na two separate ovum are fertilized with two separate sperms. So they will have different genetic material and they will be of different sexes also. So they will be having two separate placenta and two separate amniotic cavities. Twin-to-twin transfusion syndrome only occurs in monochorionic twins due to shared placental circulation. So dichorionic twinsல வந்துட்டு placental circulation is not shared because they will have two separate placentas and intertwin membrane thickness will be more than 2 centimeters. This is the intertwin membrane thickness. This will be more than 2 centimeters and the babies will be of different sexes. And also the lambda sign will be seen in USG. We'll see something about the twinning. So dizygotic twinning na two separate ovums are fertilized by two different separate sperms and they will have different genetic material also. Monozygotic twins la the zygote is already formed and from that cleavage happens. When it happens in the first to third day we will have dichorionic diamniotic. Dichorionic means they will have two separate placenta and two separate amniotic cavities, that is dichorionic and diamniotic. So when the cleavage happens in day 4 to 8, so in the day 4 to 8 la the outer cell mass form ஆயிருக்கும், inner cell massum form ஆயிருக்கும். So இந்த டைமில் நம்மளுக்கு cleavage நடந்துச்சுன்னா they will have a single placenta, monochorionic but diamniotic, two amniotic cavities. அப்புறம் நம்ம ஆஃப்டர் இம்ப்ளான்டட் பிளாஸ்டோசிஸ்ட்க்கு அப்புறம் க்ளீவேஜ் நடந்துச்சு டே 8 to 13 ஆல்ரெடி வந்து அம்னியாட்டிக் கேவிட்டி ஃபார்ம் ஆகிடுச்சு. ஸோ வி வில் ஹாவ் மோனோகோரியானிக் அண்ட் மோனோ அம்னியாட்டிக் ட்வின்ஸ். இந்த மோனோகோரியானிக் மோனோ அம்னியாட்டிக் ட்வின்ஸில் வந்துட்டு திஸ் இஸ் வெரி ரிஸ்கி. தேர் வில் பி entanglement of the cord. அப்புறம் when cleavage happens in day 13 to 15, this is after the formation of the primitive streak formed from the fused embryonic disc. This will lead to conjoined twins. So this is about the twinning. So the right answer to this question is twin-to-twin transfusion syndrome, which is seen only in monochorionic twins due to shared placental circulation. Next question. Winging of scapula is due to weak subscapularis, supraspinatus, serratus anterior and trapezius. So the correct answer is serratus anterior. So serratus anterior paralysis causes winging of scapula. So serratus anterior arises from the 2nd to 8th rib, from the lateral aspect of 2nd to 8th rib, and it is inserted into the anterior aspect. So this is the anterior aspect or medial border of the scapula. So serratus anterior is supplied by the long thoracic nerve, which is commonly injured in axillary surgeries. So when this paralysis happens, there will be winging of scapula since serratus anterior is attached to the medial border of scapula. And subscapularis weakness does not cause winging. It affects the internal rotation. And supraspinatus, it only causes abduction defects. So this initiate abduction, 0 to 15 degree abduction is caused by supraspinatus. Only that will be affected. This will not cause winging. We will move on to the third question. Keratocytes are derived from neural crest cells, neural ectoderm, surface ectoderm and mesoderm. So keratocytes of corneal stroma arises from the neural crest cells. Okay. Neural crest cells, they give rise to craniofacial mesenchyme. All the bones of the head and neck, and mostly the cells of peripheral nervous system like Schwann cells and also melanocytes. Neural ectoderm forms retina and optic nerve, but the surface ectoderm only forms the lens and corneal epithelium, not the keratocytes. So we'll see about the formation of neural crest cells. So this is the notochord. Notochord is the axial mesoderm. So this notochord will stimulate the ectoderm and convert it into the neural tube. This will stimulate the ectoderm and it will convert into the neural tube. நோட்டோகார்டோட ரெமனன்ஸ் பற்றி கேட்பாங்க எம்சிக்யூவில். ஸோ த ரெமனன்ஸ் ஆஃப் நோட்டோகார்ட் ஆர் நியூக்ளியஸ் பல்போசிஸ், அபிக்கல் லிகமெண்ட் ஆஃப் டென்ஸ் அண்ட் டெக்டோரியல் மெம்ப்ரேன். திஸ் இஸ் அ செப்பரேட் எம்சிக்யூ. அண்ட் வாட் ஆர் த டெரிவேட்டிவ்ஸ் ஆஃப் நியூரல் டியூப், அதுவும் ஒரு செப்பரேட் எம்சிக்யூ. டெரிவேட்டிவ்ஸ் ஆஃப் நியூரல் டியூப் எல்லாமே வந்து மோஸ்ட்டாக பிரெயின் அண்ட் ஸ்பைனல் கார்ட், ஆலிகோடென்ட்ரோசைட்ஸ், ஆஸ்ட்ரோசைட்ஸ் and ependymal cells. All the cells of CNS are derived from the neural tube. So இங்கேருந்து இந்த நியூரல் டியூப்லேருந்து மைக்ரேட் ஆகிற செல்ஸ் தான் வந்து நியூரல் கிரெஸ்ட் செல்ஸ். ஓகே, தே ஆர் ஃபார்ம்டு பிட்வீன் த ectoderm and the neural tube. They are formed between the junction of the ectoderm and the neural tube. So the பார்த்தோம் டெரிவேட்டிவ்ஸ் வந்து மோஸ்ட்லி craniophacial mesenchyme, Schwann cells of peripheral nervous system and melanocytes. These are the derivatives of neural crest cells. We'll move on to the fourth question. Celiac plexus is formed by all except vagus nerve, lesser splanchnic nerve, greater splanchnic nerve and least splanchnic nerve. So the answer is least splanchnic nerve. Celiac plexus, they receive fibers from vagus, lesser splanchnic nerve and greater splanchnic nerve. But the least splanchnic nerve it means it supplies the renal plexus and it is not a part of celiac plexus. So celiac plexus it is a autonomic, it provides autonomic innervation to the upper abdominal organs only, like stomach, liver, spleen and pancreas. So it is formed around the celiac trunk and superior mesenteric artery. It provides only autonomic innervation to the upper abdominal organs. And the least splanchnic nerve which provides autonomic innervation to the to the kidneys. So it is a part of the renal plexus, not the celiac plexus. We'll move on to the fifth question. When does the ovary contain maximum oogonia? At birth, 3rd month of intrauterine life, 5th month of intrauterine life and 7th month of intrauterine life. So the answer is 5th month of intrauterine life. Maximum number of oogonia, 6 to 7 million, occur at 5th month of intrauterine life. So after this period, there will be atresia and the oocytes will be reducing in number. At birth, we will have only 1 to 2 million oocytes. At puberty, the counts further fall to 300,000 to 400,000 oocytes. We'll move on to the next question. Embryo is extremely susceptible to teratogenesis during 3rd and 9th weeks, 1st and 5th weeks, 15th to 20th weeks, 10th to 15th weeks. So the week 3 to 9 they correspond to organogenesis. So this is the most susceptible period for teratogenesis, which is week 3rd and 9th. So when the child is exposed to the teratogens at this stage, there will be major structural malformations. So before implantation it is just all or none phenomenon. After organogenesis, only functional defects will occur. So 3rd to 9th weeks are most susceptible to teratogens. In adults, which bone is red marrow replaced by yellow or fatty marrow? So in adults, the shaft of long bones are replaced by yellow and fatty marrow, but the red marrow persists in axial skeletons like vertebra, ribs, sternum and pelvis. But clavicle, they retain some red marrow due to the membranous ossification pattern. And in adulthood, yellow marrow can be converted into RBCs in case of severe anemia. So which structure keeps the cystic duct open to drain the gallbladder? Spiral valve of Heister maintains the patency of the cystic duct. நம்ம அடுத்த ஆப்ஷன்ஸும் பார்க்கலாம். யூஸ்சுவேஷன் வால்வ், இந்த வால்வ் வந்து ரைட் ஏட்ரியமில் தான் இருக்குது. ஸோ இட் இஸ் லொக்கேட்டட் இன் த ரைட் ஏட்ரியம். ஸ்பிங்க்டர் ஆஃப் ஆடை, ஸ்பிங்க்டர் ஆஃப் ஆடை இட் கண்ட்ரோல்ஸ் த, இது வந்து பைல் ஃப்ளோவை கண்ட்ரோல் பண்ணும். காமன் பைல் டக்ட்லேருந்து இன்டெஸ்டைனுக்கு ட்ரெயின் ஆகிற பைலை வந்து கண்ட்ரோல் பண்ணுற டக்ட், இதுதான் வந்து ஸ்ட்ரக்சர் ஸ்பிங்க்டர் ஆஃப் ஆடை, நாட் த சிஸ்டிக் டக்ட். தெபேஷியன் வால்வ்ஸ் ஆல்சோ present in the right atrium. It is related to the coronary sinus. So the answer is spiral valve, which keeps the cystic duct open to drain the gallbladder. எப்படி இது ஓப்பனாக வச்சுக்கோன்னா, because of the presence of mucosal folds, it will prevent the collapse during the bile flow. So this is the sphincter of Oddi. It opens into the second part of duodenum. We'll move on to the next question. So Riedel's lobe is seen in gallbladder, spleen, stomach, liver. So Riedel's lobe is seen in liver. Riedel's lobeன்றது ஒரு anatomical variation of the liver. ஸோ இது வந்து லிவரில் வந்து ரைட் லோப் ஆஃப் லிவரில் வந்து ஒரு டங் ஷேப்ட் ப்ரொஜெக்ஷன். இது யாரில்னா மோஸ்ட் காமன் இன் விமென். இதனால் வந்து இது ஹெபட்டோமெகாலின்னு நம்ம வந்து கன்ஃபியூஸ் பண்ணிப்போம். இட் ஹேஸ் நோ பேத்தாலஜிக்கல் சிக்னிஃபிகன்ஸ். இட் இஸ் நாட் அசோசியேட்டட் வித் ஸ்ப்ளீன், ஸ்டமக் ஆர் கால் பிளாடர். ஓகே, ஸோ Riedel's lobe is seen only in liver. We'll move on to the next question. The posterior wall of femoral sheath is formed by iliac fascia, transversalis fascia, psoas fascia and fascia lata. So this is the posterior wall of femoral sheath. It is formed by the fascia iliaca or iliac fascia. The anterior wall of femoral sheath is formed by fascia transversalis. So fascia transversalis forms the anterior wall of femoral sheath. Fascia iliaca forms the posterior wall of iliac sheath. Identify the wrong pair. So ulnar nerve supplies flexor carpi ulnaris. This is a right statement. Median nerve supplies palmaris longus is also a right statement. Musculocutaneous nerve supplies coracobrachialis, also a right statement. But flexor carpi radialis is supplied by the median nerve, not the radial nerve. So this is a wrong pair. We move on to the next question. Renal nerve is also, so the least splanchnic nerve is also called as renal nerve. So renal nerve is the least splanchnic nerve. The least splanchnic nerve supplies the renal plexus. As we already saw, the greater splanchnic, lesser splanchnic nerve supplies the celiac plexus, and the least splanchnic nerve supplies the renal plexus. And there is nothing called as lowest splanchnic nerve. We'll move on to the next question. The opening of inferior vena cava inside the right atrium is guarded by a fold of endocardium called as Eustachian valve. So the Eustachian valve is a crescent shaped fold guarding the IVC opening into the right atrium. Okay, so idoda function enna, it helps to fetal circulation, fetal blood flow foramen ovale வெளியே எடுத்துகிட்டு போகிறதுக்கு கைட் பண்ணுற valve இது. ஸோ தெபேஷியன் valve வந்து it guards the opening of coronary sinus, not the IVC. And the tricuspid and the semilunar valves, they have no role here. Yes. So we'll move on to the next question. In the periods of growth, embryo is defined as, so எந்த வீக்கில் நம்ம வந்து எம்ப்ரியோன்னு கிளாஸிஃபை பண்ணுவோம்? In the week 3 to 8 we call it as embryo. So in the 3 to 8 weeksல தான் வந்து organogenesis நடக்குது. 0 to 2 weeks வந்து நம்ம வந்து ப்ரீ எம்ப்ரியானிக் ஸ்டேஜ்னு சொல்லுவோம். இட் இஸ் ஆல் ஆர் நன். 8 வீக்ஸ்க்கு அப்புறம் ஃபீட்டஸ் பிகின்ஸ் டு க்ரோ அண்ட் மெச்சூர். 9 to 12 வீக்ஸை வந்து நம்ம வந்து ஏர்லி ஃபீட்டல் பீரியட்னு சொல்லுவோம். 9 to 12 weeks is early fetal period. All these are separate MCQs. Next question. Lens plate of human embryo forms in the 4th week of intrauterine life. So lens plecoid and the lens plate appear around the 4th week. நம்மளுக்கு 4th weekல தான் lens plecoid and lens plate will appear. So அதிலேருந்து தான் வந்து it will invaginate to form the lens vesicle soon after. Eye development begins as early with the optic vesicle formation. 6 to 8 weeks la vandu it will further differentiate to form the lens. So the answer is lens plate is formed at 4th weeks of intrauterine life. We will move on to the next question. In Erb's paralysis, the following deformity is present. So what is Erb's paralysis? Erb's paralysis is the injury to the upper trunk of brachial plexus. Upper trunk of brachial plexus is C5 and C6 nerve roots. So this is இதில் வந்து Erb's point injury நடக்கும். Erb's point என்றது meeting point of 6 nerves. We'll see what the 6 nerves are. C5, C6, suprascapular nerve, nerve 2 subclavius. This further divides into anterior and posterior divisions. So this is called as Erb's point, where the 6 nerves meet. Erb's paralysis எப்போ நடக்கும்? Traction during childbirth, when the head is abnormally abducted, when the angle between the head and the shoulder increases during abnormal due to difficult labor or during traction during childbirth. So அப்போ என்ன ஆகும்னா the C5 and C6 nerve roots will be injured and also the Erb's point will be injured. So இதில் வந்து என்ன deformity நடக்கும்? The arms will be hanging towards the side. எதனால? The baby won't be able to abduct the arm. ஆமோட abduction இருக்காது. So abduction இல்லைன்னா the arms will be adducted because of paralysis of deltoid muscle. அப்புறம் elbow will be extended due to paralysis of biceps brachii. Biceps brachii is a powerful flexor. Because of the paralysis of biceps brachii, the elbow will be in the extended position and also forearm will be pronated. Same due to the injury to the biceps brachii, which is also a powerful supinator. So Erb's paralysis is due to upper trunk C5 and C6 injury. The deformity is called as waiter's tip deformity or policeman's tip hand. So the arm will be adducted due to loss of deltoid and supraspinatus action. The elbow remains extended due to the loss of biceps brachii and brachialis. Forearm will be pronated due to loss of supinator and biceps. Overall, the limbs will be hanging by the sides with a characteristic waiter's tip deformity. We'll move on to the next question. Central venous cannulation can be done through the following veins except. So central venous cannulation can be done through internal jugular vein, subclavian vein and also sometimes femoral vein, but it cannot be done in the popliteal vein. It is not the preferred site because popliteal vein lies deep in the popliteal fossa and also popliteal vein is in close proximity. Tibial nerve பக்கத்திலே போறதுனால it is more prone to injury to the tibial nerve. So we are not preferring popliteal vein for central venous cannulation. We'll move on to the next question. All of the following statements are true regarding the suboccipital triangle except. So the roof of the suboccipital triangle is formed by semispinalis capitis and longissimus capitis, which is a correct statement. So it is bounded inferiorly. Inferiorly it is bounded by the obliquus capitis inferior and superolaterally it is bounded by the obliquus capitis superior. So the content of suboccipital triangle is vertebral artery and suboccipital nerve. But the floor of the suboccipital triangle is formed by the posterior atlanto-occipital membrane. It is formed by the posterior arch of atlas, not the anterior arch. Anterior arch lies anteriorly. The floor is formed by the posterior arch of atlas and the posterior atlanto-occipital membrane. So we'll move on to the last question. Lymphatics from the glans penis drain into the deep inguinal group of lymph nodes. So this is also called as lymph node of Cloquet. Okay, superficial inguinal lymph nodes, they drain the penile skin and the scrotum, not the glans penis. And para-aortic lymph node, they drain the testis. Pre-sacral lymph nodes, they have no role in penile drainage. So the lymph nodes of Cloquet are present in the femoral canal beneath the inguinal ligament. So they drain the lymphatics from the glans penis. Thank you.